So now I invite my colleague Dr. Anubhav Goyal, and he's also giving us a very practical talk. Like Anubhav has an important role in expanding the ROP work at Giridhar Eye Institute. So he's going to share his experiences to encourage youngsters to take up ROP work and to know how to overcome the various roadblocks you have. Over to you, Anubhav.
Thank you, ma'am. Thank you for giving this talk. So I'll be talking upon setting up ROP program. So as Dr. Divya has already told, ROP and Sir has already told, ROP blindness is a premature birth are huge in numbers in all over world, and India is the kingdom of all the ROP premature births. And if you see this 1 out of 10 babies who are having premature ROP is actually 18,000 who needs treatment out of 3.5 million premature births. 18,000 is a big number. We have to deal with such a big number. We need more and more understanding and proceeding. So I'll just cover a few important things. We all should understand the golden rule of ROP for screening. 1, 2, 3, 4. One is premature baby should be screened within 1 month of birth. All babies less than 2000 gram should be screened, and all babies less than 34 weeks of gestation should be screened. Babies who are extreme premature less than 28 weeks should be screened a little bit earlier, like 2 weeks of birth. But otherwise, usually what Dr. Divya told, our ROP present usually 3 to 4 weeks after birth only. We can delay the screening till 1 month. So screening should be done preferably under good monitoring, preferably in ICU, but you can do in ROP, in your OPD also, when the baby is stable and discharged. But if the baby is still in the ICU, you should make sure you should go to an ICU, and in the hands of trained person only with under monitoring, you should screen the baby. For screening, the ROP drops has to be made. There are a lot of companies which are providing ROP drops. But then the standard drops what we are getting for adults, we can use them and dilute it with 50%, and you can use these same drops for dilating the ROP babies. These have similar concentration of tropicamide and phenylephrine, which is recommended for ROP drops. So the important thing is teach NICU staff how to instill these drops, because extra putting drops, keeping this drop contact for skin for long time can cause systemic absorption and can cause fatal systemic complication like bradycardia and apnea. So immediately after putting the drop, you have to clean the skin and eyelids so that it should not cause any systemic complication. And for screening, eye should be properly dilated. Improper dilatation, small pupil, what we do in adults like pinpoint imaging should not be done. ROP is a problem which its dilatation itself is important, give you a very good clue that it's not a severe urgent ROP. If dilatation is not there, you have to be cautious. It can have iris new vessels, NVI, and an advanced stage AROP type of picture. So dilatation should be taken care of very nicely. So examination, as I told, should be done in an ICU, and treatment is also should be done in an ICU. You can actually screen babies through the incubator also. So if babies should be taken care of, baby should be taken as priority. Screening should be done as per the baby's comfort, not as per your comfort, and all the parameters should be taken care of very nicely. Always monitor and resuscitate baby during screening and treatment. Babies can have apnea and all during their screening part also. So the contact person in an ICU is the most important person which will coordinate with you for screening and treatment. That person is preferably a neonatologist from the team of neonatologists and a nursing staff. So that one person or a coordinator of that ICU that you have to keep under your constant coordination, and that person will call you for periodic screening, periodic dates, and coordinate with patients. So that person you have to identify and mark and keep that in constant loop. So key point is identify the ICUs which have huge number of premature births, keep constant touch and coordinate with them for a good ROP screening. MOU has to be signed with all these hospitals, because if you don't sign ROP, they might call you, they might not call you, and they might call someone else. But the problem is, if they are not calling regularly, premature screening ROP screening can be delayed and can cause further worsening of ROP. So MOU has to be signed so that periodic screening can be done. Identify the pediatrician in charge and keep them in loop. What is happening with the ROP, what baby they need to be screened or baby need to be treatment, what is the stage, everything you keep, you you explain everything on the your consecutive visits, so that they should get an idea that what is happening is according to and how they can manage the ROP and presentation on all the babies. So identify a staff nurse or coordinator which you have to keep in the loop. And most important thing is, fees is the most important thing which can shut down your screening. This is the most important part which I have personally feel in my journey in ROP, that fees matters a lot. If you charge a lot, initially you can pick up, but then slowly the screening might come down. So fees or the money what you are charging for the screening or treatment should be comfortable to the team and to the patient both. So keep a fixed day every week. You can shift 1 or 2 days earlier or later, but fixed day every week should be there for particular hospitals, so that they can coordinate with the baby, because baby might be needing ENT follow-up, pediatric follow-up also. So they can combine ROP screening with that, and it will be easy for them also, because priority is a comfort of pediatrician and the baby, and you have to do ROP screening with their comfort also. So keep register of ICU with you, not to miss any finding, and to give you detailed advice, and you have to keep the data of baby with each and every finding. Baby identification card is a very important thing which gives an idea of how the ROP is progressing to the pediatrician and to you also, and which will help parents to keep the finding and for their future follow-ups with the other doctors in later life. So this is a ROP documentation form which you can give to the pediatricians and can keep in the file, so that they can you can record your findings. This ROP card you can see on the left side, you can keep all the details in your hand, and right side you can write all the details, what is the follow-up, which date you screen, and slowly you can check how the baby is going on in terms of ROP. So baby is not born with disease, but with your efforts, this disease can be taken care of very nicely. And since it has a lot of medical legal implications, a lot of people are fear or not to do it. But now, with the more awareness and understanding that if you screen timely, if you treat timely, this is not a medical legal issue anymore. You can take care of babies. We need more manpower to take care of ROP. We need more instrumentation to take care of ROP, because number is still huge and we have to do more. So there are a lot of medical legal cases against ROP. Mostly in most of the cases, pediatrician is being blamed, but yes, we are also a part of that blame. So we have to take care of it very, very cautiously, but very strongly. And counseling parents, informing NICU staff, everything has to be done very nicely on every visit, and you have to keep the details and you have to be transparent to the parents, make the parents understand what is happening. So here comes you can use these posters which give you information of screening, and here comes the importance of imaging, what sir has already told. This is an image which I usually prefer to keep in my mobile to show to the parents how the stages are seen. So either a ready image you can keep, so that parents can understand what is stage is going on, which is what stage, and what stage need treatment, and what are you seeing there if you don't have imaging thing in your hand. So moral and legal responsibility of getting the baby to the ophthalmologist is basically by pediatrician. Keep him in loop. Trained ophthalmologist is important, or a trained optometrist with a CAD cam can be a good your assistant, who is available constantly. You should not change the ophthalmologist. You should not changing ophthalmologist, changing assistant is not a good thing for screening. As I told, fixed day is important, and even single critical and admitted premature baby is important and should not be missed for screening. For each baby, check if the baby you have basically for each baby you have to check the systemic parameters also, why if the ROP is not maintained, and oxygen saturation, other body parameters, because anemia is the most significant risk factor. What we have seen with the worsening of anemia, you can see worsening of ROP also. Oxygen concentration also is a secondary risk factor, but is also important risk factor. So these are multiple imaging modalities which already sir has told. You can use both. A smartphone is a good device which you can take it for periphery when you don't have anything. At least some documentation is important, though it is not legally accepted, but it is an important device which you can use when you don't have anything to explain to the patients. At least something should be, you need to prove what is you are seeing to the pediatrician and to the parents. So these kind of images you can get from smartphone also, though it is not good, but then for rare cases it can be used. ROP card should be kept for at discharge to counseling parents. And this is the most important thing. I used to screen one hospital where doctor used to say, Anubhav, just see red reflex and tell what baby is okay or not. Because these are priority hospital, VIP hospital, we cannot take risks with the babies. So I told him, sir, I will not do anything without dilating the baby. I have to screen the baby with dilatation only. So red reflex is a fallacy. You can have advanced stages with red reflex and severe ROP with red reflex. By the time you dilate, baby will come with a white reflex. So don't screen baby just for red reflex. Dilate properly and screen retina. ROP has severe lifelong implications with lifelong blindness. So termination ROP should be done after retina is fully vascularized, without treatment or with treatment. We have many unsung, silent and happy stories if ROP is taken, and ROP is taken as enjoyment, and it should not be taken as a burden. This is a case example of a girl child who is doing very good in her class with 6/9 vision, and you can see the amount of laser scars. So there are medical legal implications of ROP related blindness. Early screening and timely treatment plays an important role in ROP prevention. Thank you.
Thank you, Anubhav, for sharing your experiences and giving many practical tips about